So I have started recording and we're rolling. So, Becky, thanks very much for joining me on the John Doe podcast. How are you doing?
Thank you for having me. Yeah, I'm good. Thank you. How are you?
I'm very well, thanks. So, to start off, perhaps you could introduce yourself for our listeners and tell us. I know you're coming to us on the podcast anonymously, but perhaps you can tell us a bit about your background and your position in the NHS, and then we can start talking about some of your experiences. So, Becky, if you could introduce yourself.
Sure. I'm Becky, and I have been working in the NHS for just over 11 years now. I work in pharmacy, but prior to that, I also studied a nursing degree for 1 year, and I left, thank God, after the first year. um, because it wasn't for me. And thank goodness that I did that, because I cannot imagine being a nurse now.
Why is that?
I just think it's probably one of the worst jobs at the moment that you could possibly have. Every nurse that I know who works in the NHS wants to leave. They are burnt out to the max. It's bad out there. But we can talk more about that if you want to later. The
Mm.
state of the NHS at the moment.
Well, yes, I mean, it sounds like a terrible state of affairs. And I mean, I assume it wasn't always like that. So, I mean, this might kind of lead into talking about your experiences within the NHS during the COVID-19 pandemic, which is sort of the main thing we were going to discuss today.
Mm.
Um, so, how have you seen things change in the NHS since you've been working there?
So when I first started in the NHS, there was definitely a sense of pride for working for an organisation like the NHS. It's a national treasure. Um, and I felt very proud to work for the NHS. All my colleagues felt very proud as well. Um, and you wanted to just do your best all the time and tell everyone you knew that you worked for the NHS. And it was quite nice to work there about 10 years ago. But I'd say certainly since COVID, and a little bit before, it's gone so downhill. I I don't feel proud to work for the NHS anymore, unfortunately. And the state of our hospitals and A&E, especially over winter months, is it's indescribable, really, what I've seen down there over the last couple of winters. You wouldn't want to be a patient there. Let's just say that.
Well, that's a very sad state of affairs.
It
And
is.
yeah, and can you, I mean, obviously we're coming up to winter now, so that's particularly concerning for, especially anyone with elderly relatives or
Mm.
who themselves is of advanced years. I mean, perhaps could you give some examples to give us a flavor of, some of the things that you've seen?
Yeah, sure. So last winter was definitely the worst I've ever seen it. Um, there were patients having to queue on trolleys, so on fresh off the ambulance, on trolleys in the corridor in A&E, because there were no beds. Um, and they were there for hours and hours and hours. And there were elderly patients who had soiled themselves in the bed, and they had no dignity to be changed. So there were doctors and nurses holding up bed sheets in the corridors to clean them up and change them to try and give them some dignity. There were patients coming in, like end of life patients who were going to pass away probably imminently, and they had no space to die with dignity. So storage cupboards were getting cleared out to fit the trolleys in so that they could at least pass away not in the corridor. There were patients waiting so long in A&E that we had one person who was admitted to ITU because they went so long without their insulin waiting to be seen in A&E that they became very, very unwell. ITU was full of patients. There were no beds. And it's going to be the same this winter as well. I mean, it's always been busy over winter. It's always kind of been, we try and get more staff in over winter to cover the pressures. But I'd say the last 4 or 5 years, it's got progressively worse now to the state where people are lying in beds in the corridor, and it's heartbreaking.
And is this happening just at the hospital that you work in, or is this something that you're aware is happening at, multiple hospitals across the country?
Yeah, it's happening everywhere that I know of. All the local hospitals around here have exactly the same issues. Friends in other trusts report exactly the same. And I don't know what the solution is, because the government are saying they're going to build extra hospitals, but they've not even started doing that yet. And I think I just can't see how it's going to end, to be honest.
Wow, well, that's a pretty bleak outlook. And I mean, as someone, my grandfather, my grandmother recently passed away, and I know that there were, I experienced some issues in terms of the availability of care. So I know that this is, a pretty serious thing when it actually hits you in your own life. And I can only imagine what it would be like for people who, I mean, it sounds like a lot of people are suffering experiences that are, far worse than what happened with my grandmother. But so this is something that obviously, has changed in recent years. So I take it from that the capacity that the NHS has in terms of manpower and in terms of perhaps resources relative to the amount of people who are in need of care has shifted, and that you are now sort of understaffed and under-equipped to deal with the volume of patients. Um, I mean, is that kind of what you've experienced, and what do you think the causes of that could be?
Yeah, absolutely. I'm sorry to hear about your grandmother. The volume of patients is increasing. We have an aging population, so obviously there are a lot more people coming in with illnesses that you get in older age. But there are also quite a lot of younger patients. I think the health in this country is not good. I don't think that there is enough preventative medicine or lifestyle, shall we say, being advocated for. And we are also now in a position where people don't want to work for the NHS. So a lot of doctors are going overseas now to work, and I don't blame them because they get paid a lot more and the working conditions are a lot better. We can't hire staff. So I left a job a year ago and they still haven't been able to recruit my position. There's just no one out there applying. The only applicants that we're getting are people overseas, but their qualifications aren't accepted in this country, so we can't hire them. And I
And why
think
do you think that is that there aren't? Sorry to interrupt. I was just curious. Why do you think it is that there aren't enough people who are applying for these roles? Do you think it's, I mean, you said that, you don't feel as proud to work for the NHS as you once did and that conditions have changed. I mean, do you think is it the pay? Is it the workload? Is it just generally what it's like to work there? I mean, what's your perspective on why it's so difficult to get people to apply to work for the NHS?
I think it's a real mix. So I think the pay isn't the best. But it's always been like that. So I don't think that we can blame it too much on the pay, because it's long been known that public service workers don't get paid a lot. I think it's more to do with the conditions and the people being overworked and not appreciated by their employer for what they're doing. The bureaucracy in the NHS is sometimes unbearable. There's so much red tape to get anything done, to change anything, to make any kind of quality improvement takes so long because it's so bureaucratic. And I think, especially for nurses, the qualification has changed. So it used to be that you could do a diploma, so a higher education diploma, and you didn't need, top grade A levels to be a nurse. It was a vocational course, and you kind of trained on the job type thing. But then that stopped, and it's now just a degree program. And the competitiveness between universities now means that they're asking for biology and chemistry at grade A and B. And I mean, I don't know about you, but if I got biology and chemistry at A level at grade A, I wouldn't be applying to be a nurse. I'd be applying to be a doctor or like a scientist or something. So I think that has definitely changed the amount of people who are wanting to go into nursing. They're not being pulled from all different sides of society, and the opportunities aren't being given out there as much. And also, the government took away the bursary, so it used to be free to train as a nurse, or a physio, or a doctor. You got 3 years free. You didn't have to pay tuition fees, but the government took that away a couple of years ago. So obviously that has deterred people as well from wanting to train.
So they've increased the barrier to entry and they've also removed the financial incentives to make it easier for people to apply. And you've got both of those factors working against being able to hire people. I mean, why do you think that's the case? Are there not people who can see that if you make it that much more difficult to hire people, then you're going to end up in this situation where you have a shortage of staff?
Yeah, it's ridiculous. I think the people who made that decision are people who don't know what they're doing. It makes no sense to me at all, especially as 50% of the nursing qualification is on placement. So these students are out there as students working and training in the hospitals, and they're still having to pay for their own tuition. It doesn't make sense to me. And all they're doing to combat this is recruit from overseas for nurses anyway. Large recruitment campaigns for overseas nurses because there aren't enough nurses coming out of British universities. Um, and we're paying money for overseas candidates to stay and live here on hospital accommodation. I mean, I don't blame the migrants coming over. A lot of them are coming from the Philippines, so they're getting paid a lot more money over here than they would back there. But it just doesn't make sense to me that they're not trying to increase the recruitment and education of British nurses.
No, that seems bizarre. And I think it's interesting as well because you're saying that they're taking away the financial incentives that were provided to make it easier for young British people to, not necessarily young, but for British people to apply to become nurses and to get that training. But what they are doing is actually providing financial support to people from overseas so that they can come in. I mean, I'm wondering how much money they are spending to get people from abroad in versus how much they would have spent on people who were here in the first place. Um, and and like from your perspective as well, like how many people are we talking about? I mean, how many people are they recruiting and bringing in, perhaps as a proportion of people in the NHS? Is that something you've seen changed in the last 10 years?
Yeah, it's been in most of the trusts I've worked in, there've been large recruitment drives for overseas nurses, just to be able to fill those gaps. Um, the trust I'm in now, I'd say every maybe every 6 months, we're getting in about 50 nurses from overseas. Um, so it's quite a lot. That's just for one trust. It would be interesting to see how much money we're spending on bringing these people over versus how much money it costs to incentivize British nurses to apply.
Yes, and I'm wondering as well, are you able to say, do you know what sort of salary these nurses coming from abroad would be starting on?
So they'd be starting on the same salary as any nurse. So if they haven't worked as a nurse before, if this is their first job as a nurse, they'd be coming in as what we call a band 5 nurse. Um, and the salary starts around 26,000 a year. Um, and a nurse would typically work at that level for a year, maybe 2 years, and then progress to a band 6 junior sister or something like that. So their career progression is good. And a band 6 salary kind of starts at about 36,000 a year.
Right. And more broadly, do you have an idea of how many people are coming into the country on this basis overall each year?
I don't know. It'd be interesting to know. I think the numbers are going to be quite high.
Hmm. Okay. Well, that's again kind of a gloomy picture, and but very, very interesting, especially to get your insight. So I think if perhaps now we could turn to how things have changed over the last 3 or 4 years due to the COVID-19 pandemic. Obviously, we've seen unprecedented changes and unprecedented things happening, over the last few years. We had lockdowns, we've had, all sorts of chaos, all sorts of restrictions, all sorts of very controversial things happening. Um, but I suppose, again, I'd be very interested, Becky, in your perspective on, what it was like for you as someone who was working in the NHS, your point of view, seeing, what happened during that time. I mean, perhaps if you could just kind of give us a sense of what that was like, and maybe, talk about some things that are particularly, um, I was going to say pertinent. Tell us, tell us your perspective.
Yeah, sure. Yeah, I'll start uh, with my full story, I suppose. So, when we went into the first lockdown, I was on maternity leave, so I wasn't at work. But my husband is also a healthcare worker, so he was working in the hospital for the first lockdown. And then I went back to work that September. So I was back to work for the second wave, second lockdown. So I can kind of report from start to finish, really. At the very beginning, the PPE, of like the protective clothing that my husband was supposed to wear, supposedly to protect himself, was not available for him. And the rules changed a lot over what was considered aerosol generating. So, what was considered to spread the virus. So, initially, it was basically anything. And you had to gown up for all patients. And then when they realised that there wasn't enough stock of masks and protective clothing, they kind of changed it to, it's if you're suctioning the patient, so if you're sticking a tube into their lungs to suction up all the gunk, that's aerosol generating. But CPR isn't aerosol generating, so you don't need to wear a mask if you're doing CPR. And then that changed again, and you did need to wear a mask for CPR. And then a cough apparently wasn't aerosol generating, which
Becky, if I could just interject, perhaps for anyone in the audience who isn't familiar, what does aerosol generating mean?
it means if so for example, you would think a cough is aerosol generating because you're producing droplets when you're coughing. So the virus is coming out and dispelling respiratory droplets, which is how the virus is spread. Does that make sense? Did that kind of clear it up?
Yeah, so if something's aerosol generating, it means that it's something that would create a dispersal of particles, droplets that would potentially contain the virus and therefore would be a risk of infection.
Exactly. Yeah. And the rules on that just kept changing, and it kept changing, for the whole kind of 2 year COVID debacle. And as a result, so many healthcare workers caught COVID, including my husband, and had to take time off work, obviously, because they were either not well or we weren't allowed to come to work when we had COVID. And it just didn't make sense to any of us, because surely you just want to protect your staff as much as possible from catching not just COVID, but anything really, because you have this influx of people into the hospital. You don't want your staff going off sick. You need your staff there. And the supplies of the masks and stuff, just they weren't there. And I suppose that's what they're looking into in this COVID inquiry, is why, and what could have been done better.
So you're saying that staff were expected to continue to treat patients, even in situations where there was a clear risk of infection, even when the NHS staff themselves had not been provided with sufficient PPE, to have any chance of realistically protecting them from that infection.
Yes. And this was mainly when COVID kind of first started. So it was leading up to the first lockdown, and then after that lockdown, for the second wave, that changed, and there were enough supplies, and you couldn't get enough masks. Like there were so many masks around, so that wasn't a problem. But for that first wave, when everyone was frightened and scared and didn't know what was going on, healthcare workers were continuously expected to be exposed to the virus, because there weren't enough supplies.
Tell us about how that worked in terms of the managerial structure of the NHS. You know, who was making this decision? Who was saying you still have to go in there and treat this patient even if you don't have the PPE? And what ability did NHS staff have to protest against this and to say, look, no, I'm not going to put my life on the line here. That's not fair. And also, what sort of repercussions would they have faced if they did refuse to follow orders, so to speak?
Um, Normally, these things are decided with the infection control team, which is made up with some specialist nurses and doctors who work just in infection control. So they'll do audits all around the hospital, and then kind of create incentives to try and improve the control and spread of infections. So it would have been a combination of that team and probably the executive team, managerial team of the hospital. And then also at a government level, because this was happening everywhere, not just in a couple of trusts. There certain professions could probably refuse. I know for me in pharmacy, if I don't want to go and see somebody and I don't, I'm not putting the patient at any harm for doing that, so I'm not really sanctioned for that. But for the nurses and the doctors and the physios, if they were to refuse, then I don't know whether they would be in a lot of trouble per se, but it would certainly be frowned upon enough to discourage them from doing that. Like, I don't know any doctors and nurses who refuse to see patients. I think that's the beauty of the people who work in those professions, is that they were putting themselves at risk for other people. And I think that is another reason why there are so many staff shortages now and why there are so many people wanting to leave, because people were exposing themselves to this and getting sick and working 15, 18-hour shifts to help patients over these periods of time, and the government and hospital management haven't appreciated them at all.
Yeah, that's it's quite upsetting to really think about that, especially thinking back and seeing headlines of doctors who even lost their lives by contracting COVID while they were on the front line trying to save patients. I mean, do you have an idea of the numbers of people who've left the NHS as a consequence of this?
I don't have numbers, but it's I imagine it would be a lot. And not just left, but also discouraged from even joining, I think. So it's now pretty, like, with all the strikes that have been happening, it's pretty obvious that people aren't satisfied working for the NHS. So I imagine the numbers are quite high.
And with those strikes, are the people going on strike dissatisfied over pay, or are they also unhappy about conditions and other things? Like, what's the important issues for the people going on strike?
Well, they are striking over pay, but it's also conditions. And I think really it comes down to the conditions because, like I said earlier, the pay's never been great. The pay's, it's never been something to brag about, but people still wanted to work for the NHS, and nursing courses and medical courses were still, oversubscribed at universities, that lots of people wanted to join healthcare. So I think it's kind of an element, and I suppose it's the easiest thing to change when you're striking. Like, asking for a change in conditions is never going to happen. But asking for a pay increase is, as small as the percentage is that they gave us, there is a little bit of an increase. I think it's mainly down to the conditions of the work.
That makes sense. And this might be a bit of a tangent actually, but it's interesting. So I remember you mentioned that some of these doctors were on, 18-hour shifts. Something I know online that's kind of become more known recently is just how much lack of sleep can impact a person's health. I'm sure anyone who follows any podcasts on health will have, seen people sort of talking about how this can impact your immune system in particular, among so many other things. Um, Dr. Matthew Walker wrote a seminal book called Why We Sleep, which should put the fear of God into anyone who reads it about the number of impacts a poor night of sleep can have on your health, but certainly cumulatively. And I'm wondering, do you think that yeah, I've always just thought it's strange that NHS staff, medical staff generally, are expected to work very long shifts, often um, with hours that you would think would be very, very disruptive to them being able to get enough sleep to, remain healthy. Is that I'd again, it's a bit of a tangent, but I'd be interested in your perspective on that.
Yeah, shift work is a killer. I am lucky I don't have to do it in my job. Um, but yes, nurses and doctors who have to do these shift patterns, their their health probably is affected, most definitely is affected. The 18-hour shifts that I was talking about, they're not set by the hospital. So normally it's a 12 or 13-hour shift that people will do, but during very busy periods, people will often do unpaid overtime, just to help out their colleagues. But yeah, I mean, and these people, they have to do shift works through the whole of their career. It's not just for junior staff. So you're talking from maybe age 25 when you join until sometimes when you retire, especially as a nurse. Consultants don't have to do night shifts as much, but you still have certain areas of medicine where consultants will be on call throughout the night. Yeah, I think healthcare workers are notoriously not the healthiest people in society.
Yeah, there's a dark irony to that, and it
Mm.
seems very sad that they should be expected to make so much of a sacrifice with regard to their own health when they are, you know, devoting their lives to helping other people not just improve their health, but to overcome life-threatening conditions. Um, so yeah, I mean that is again a bit of a tangent, but I just have this thought of staff being so overworked that they're not getting enough sleep to maintain a strong and healthy immune system, being expected to go and face down a new and very dangerous and in many cases deadly disease. And on top of that, they're not even being provided with enough PPE to be able to protect themselves from the risk of infection. So yes, I can see just from that how NHS staff might feel that they were not being appreciated because it certainly doesn't seem like they were. Um, Now, I suppose another thing that will be really interesting, Becky, to get your perspective on is the vaccines. Now, of course, there were multiple vaccines over the years of the COVID pandemic, and different governments around the world responded differently. There were different measures, and also the information that we were receiving from the government and from the NHS did seem to change over time. But I'd be very interested to hear your perspective on the NHS vaccine programs from your point of view.
Yeah, sure. So I think um, where the advice and everything kept changing, I think because everything was happening in real time, that is something that would have happened during clinical trials over many, many, many years. You would have seen changes in advice, changes in dosing, changes in regimens, etc., happening during clinical trials over about the 20 years it takes for a vaccine to get to market. But
20 years.
yeah, it takes a very long time for from start to finish, from the development of the vaccine until it's, or any drug really, until it's rolled out to market. But because that was happening in real time, you saw how much things changed. And I think that has definitely damaged the trust that we have in healthcare and pharmaceuticals. Not that we should trust pharmaceutical companies, because they're notoriously corrupt. So I think that's why there was a lot of chopping and changing. Going back to the start of the pandemic, I had, there was always whispers of when is this going to end? Is there going to be a vaccine? And I remember speaking to lots of colleagues of mine, and we were all kind of saying, God, I don't think I'd take a vaccine if it's, only been in development for 6 months, or how would you know it's safe? Like, it wouldn't have been tested in enough people. And then within a blink of an eye, there's a vaccine and everyone's taking it. And it was really interesting, including myself. I'm not saying I was above all this at all. I was very much the same. It was rolled out, and I was in the queue to get it. And it's interesting looking back and trying to think about how that happened, how my thoughts went from, oh, I wouldn't touch a vaccine that had only been developed over 6 months, to, yeah, sign me up. Can't wait to get my next dose. Like, I don't know what your
Yes.
thoughts are. If you can
No, well,
pinpoint.
that's no, it's very interesting. I was just going to ask, what influences you think it might be. I mean, do you think it was because there seemed to be a lot of messaging from the government and from the NHS that you could almost fairly characterize as propaganda. They were definitely trying to influence people to get the vaccine and pressure people. You might say. And then that kind of ramped up and up and up. And again, it was different in different countries. There seemed to be a higher penalty for not taking it, various mandates. Um, but it's something that I found very interesting during those times, was how there seemed to be kind of people had a desire to conform to, this is what we're doing. There's a big crisis going on. We're doing this, we're doing that. So the masks, I think, and that's another interesting thing to talk about. Everyone is going to wear a mask, and here's what we're doing to show that we're all kind of doing our bit. And I suppose perhaps that might even relate back to what you said about how, people working in the NHS wanted to continue to do overtime unpaid. Perhaps there was an element of camaraderie, and that we're all uniting together to fight against an existential threat. But yeah, it was very interesting to see how some people did seem to kind of flip on the vaccine. But again, from your point of view, as someone working within the healthcare profession, um, I mean, yeah, what do you think it was that made you go from being very skeptical and knowing that, this time scale of 6 months is, nothing compared to the 20 years that you said it usually takes for, a vaccine to get to the point from development to being considered safe. Um, I mean, what's your sense of what it was that really changed your mind at the time?
I think you're right with the propaganda aspect of it. I think there was definitely, you had the government, you had the drug companies, you had hospital management, you had doctors, trusted people, or supposedly trusted people in society, telling you it's safe, don't worry about it, we've tested it, it's tested, it's safe. So you just believed what these people were saying because they were doctors, because they were scientists. And it's interesting to me that we were told it's safe, it's tested, just have it. But we weren't really. I'm sure some of the doctors and nurses may have been given training and education on it, but like from my level, there was no education on it. And considering that it was a brand new vaccine as well, and the fact that there are no other mRNA vaccines out there, there was no education on it. And we were expected to advocate for the vaccine and never say anything bad about it. Um, and if you did, you were completely shunned by colleagues. And you would see that a lot on Twitter as well, in the public, or any social media. If you dare question the vaccine, a bombardment of hate would come at you. When really all people were doing were just saying, are you sure this is safe? Could there be any adverse effects from this? How do you know? And
And
we
that
need
seems like the
people like
most
that in society. We need people to question.
absolutely. Sorry, I interrupted you. I was going to say that sounds like the most sensible, logical question that you would hope people are asking if they're expecting you to take a new drug. And I also wanted to ask, because you said that you didn't receive any sort of training on this vaccine. Is that would you usually expect to have training if a new medication was coming in that you were going to be administering in this way?
Um, yeah, quite often if there's a new drug that is coming to our formulary, which a formulary is a list of medicines that the hospital will have that they can order freely. So it's what we use within the hospital. So if there's a new drug being added to that, quite often we'll get pharmaceutical reps from the companies come in to give a talk about it, which is obviously biased, and they bring cake and food and whatever to encourage you to go to the lecture. But actually, it's quite interesting to learn about the drug, and it's important as well, because if you're expected to counsel patients about new medicines, then you need to know what you're talking about. And if drug reps don't come in, then normally senior colleagues who have been to conferences, etc., will come and pass on that knowledge to the mass department. But that didn't happen at all. There were no drug reps that came in to talk about the vaccine. Maybe because they couldn't, because it was COVID and you couldn't see anybody. But yeah, there was no education, no training, and kind of I found that a bit strange because, like I say, it's not only a new vaccine in the sense that COVID's a new disease, but it's a new vaccine as a whole. The mRNA vaccine is new. So I would have personally liked to have had a bit more information about it, especially as I was expected to advocate for it.
Yes, and also to take it yourself. And just as a bit of clarification, obviously there were various different vaccines that were used, or vaccines produced by different companies. So there was AstraZeneca was producing one. Could you tell us a bit about the different vaccines that came out, and perhaps also would you be able to say a bit about how an mRNA um, vaccine, if you can even call it that, is different from what people conventionally think of as a vaccine?
Yeah, so the only brands that we had in the hospital were Pfizer and AstraZeneca. And they'd come in and out of stock depending on what was available at the time. Um, there wasn't really any preference apart from, I think, from memory, you may have to fact check me on this. Um, but I think there was a point in time where we weren't giving AstraZeneca to people who were at risk of clots because of the reported side effects of people having brain aneurysms and strokes and dying. So I think that changed a bit. Do fact check me on that though before you put that out. Um, And in terms of the mRNA vaccine, I'm I'm sad to say I can't really give an explanation because I still haven't received training on the mRNA vaccine.
And this is the 9th of December 2023 that we're recording this, at which
Yes.
point no training has yet to be forthcoming. I know that I think it's Dr. Peter McCullough and Dr. Robert Malone are two medical professionals who spoke about this. I think they were both banned on Twitter at some point, as it was then, now it's X, um, and went on the Joe Rogan podcast. And I remember, I think it was Dr. Robert Malone, who was actually one of the people who developed the mNRA technology, who was then actually raising an alarm about the risks associated with it, and the risks indeed associated with the vaccination. And that I think was part of the reason that there was an attempt to sort of cancel and silence and censor what he was saying. So I think if people want to kind of learn a bit more about what mNRA is, I do remember hearing him talking about it on some of those podcasts. Um, and so you took the vaccine. So when did you take the vaccine? Which ones did you take? And did you personally notice any side effects?
So I had my first dose the week that it came to market. The healthcare workers were one of the first people to have access to it. So had my first dose, then I think it was around January. And then since then I've had 4 doses. My last one being September 2021. And I haven't had it since. Mainly because I don't really see the point in having it anymore. The virus now is not as deadly as it was. And I think I just had AstraZeneca brand, because that was just what was available at the time. I didn't get side effects for my first few doses, but I did experience something that's quite interesting that I'll just quickly say. I joined a new, I started a new job in 2021, and I had to have a full course of vaccines because my GP had lost my vaccination records. And when you join the NHS and you're in like a frontline service and you're seeing patients, you have to have been vaccinated against certain diseases. And unfortunately, my old trust and my GP had lost my vaccination record. So I had to start this all over again. So within the space of 8 weeks, I had COVID, flu, 2 doses of MMR, and 2 doses of hepatitis B vaccines. And then a week after the last dose, within that 8-week period, I developed a rash all over my body. And it was very itchy and painful, and it covered my whole body. And I approached my doctor about it, and I said, I'm a bit worried because I'm due a 3rd dose of hepatitis B, and I'm a bit worried about having it because I've developed a rash. And it's well known, if you're exposed to something and you get a rash, it's kind of a warning sign that if you expose yourself to it again, you could have a more severe allergic reaction. So I was a little bit worried about perhaps having an anaphylaxis or something if I get another dose, which I think is a sensible thing to query. And I was completely shut down. I was completely dismissed and told there was no way that this could have been as a result of the vaccine schedule that I just had. Which is a hell of a lot of vaccines to have in 8 weeks. And it just blew my mind that they couldn't admit that this could have happened from a vaccine. They couldn't allow any distrust in this process. And I'm not even distrusting it because I took the vaccine. I couldn't believe that they wouldn't even consider highlighting that as a side effect.
No, that seems bizarre. It doesn't seem like a scientific way to approach anything like that when you can see a clear, you've taken this vaccine. That's, that's obviously something that, people do have reactions to vaccines, and then you've had this very unusual side effect happen where you've had a rash all over your body. The idea that you could just out of hand dismiss the connection to that, and without even positing any other thing that could have potentially caused this rash, um, just not even wanting to investigate it, not thinking, okay, well, which vaccines did you take? Could they have done it? But just dismissing it out of hand, that seems reckless.
Yeah, and quite worrying because, like I say, it could have been a warning sign that I would have developed an anaphylaxis to the next dose that I have, or the next exposure. Um, and it just blew my mind. And I think this is now a culture where if you question anything now, you're labeled as a vaccine denier, or like right wing, or anything. You're not allowed to question anything anymore. And it's sad.
It is sad, but it's also dangerous. And I
Mm.
mean, the idea that someone having questions about the safety of a medical intervention is indicative of political affiliation. I mean, there's just no connection. I mean, like, why would it have anything to do with whether, which party you want to vote for, or whether you're more into capitalism or socialism, whatever? That has nothing to do with whether or not a medical procedure is safe, whether or not you've been given adequate training or information about it, whether it's been adequately tested. That shouldn't be a political question. And I think it's quite disconcerting to sort of see how politicized everything seems to have become, to the point where something that should be, completely separate from politics, a very sensible question that anyone considering a medical procedure should ask themselves: is this safe? Um, and would hope to be able to ask their doctor, is this safe? And for the doctor to actually address the question, that fundamentally important question is going to be dismissed out of hand by the very medical professionals we would hope to be, trusting with decisions that could affect our health, because of a political climate of censorship and just a complete, as you said, inability to accept the fact that there could be side effects to vaccines. I mean, why do you think it would be that there's this kind of, they now treat it almost as a tenet of faith that you cannot question the vaccine. You have to have faith in it. If you question it, it's almost like they're treating you like a heretic. I mean, why do you think it is that there is now such a closed-minded attitude?
I think it's going back to what we were saying about the propaganda around the COVID vaccine. I think that has led now to people being completely brainwashed, into not questioning anything like that. I'm not an expert, so maybe the doctor's right and there is no connection. But I think to dismiss someone's concerns is not the right way to go about it. Um, I think people's concerns should be spoken about, and having a conversation like you and I are having right now, where you can just openly say something and not be judged. And you would expect that from a doctor, but unfortunately, you're right. Everything now has become so politicized that even doctors now have been drawn in to this propaganda, and they don't even realize it's propaganda. I think that's a sign of a successful propaganda campaign.
Yeah, absolutely. You don't even notice it. Yeah, it's it's really worrying that we've got to a point where, we feel like we can't trust the people who are in these positions of authority because they just don't seem to be considering things objectively. They seem to have lost that objectivity that we were used to and that gave us confidence to trust them in the first place. If it seems like they're acting more in a religious frame than in an objective scientific one, it's no wonder that this trust has been dwindling. Um, I think it's also interesting though with coming back to side effects from the vaccines, because I remember you mentioned earlier that one of the vaccines was not recommended for certain patients because it was known to cause blood clots. And I've heard a lot of reporting of various side effects um, from the vaccines. We can kind of get into that more um, in the conversation. But I mean, perhaps we could start there. What what sort of side effects, such as blood clots, have we seen? What can that cause? What's the impact on people who are having that? And what sort of scale was this seen at?
Yeah, so we definitely noticed during COVID an increase of people coming in with blood clots. Um, and when I say we noticed this, this was discussions, on the ward. Oh, there's a lot of people coming in with blood clots recently. Have you noticed? Oh, yeah, there's lots of people. So I don't have any stats for it, but it was definitely something that we noticed more. Whether or not the clots were being caused by COVID, because we know that COVID does cause clots, or whether it was a result of the vaccine program is still undetermined. But um, there were reports of the vaccine side effects being blood clots. So without doing a study, it's impossible to tell whether it was one or the other. Um, but blood clots, depending on where they form, you can get blood clots in your arms and legs, which is what we call a DVT, which is a deep vein thrombosis. And they can be dangerous because the clot can travel from your leg to your heart. And if you have a clot in your heart, then you will have a heart attack. It can also travel to your brain. If it travels to your brain, you'll have a stroke. And as you know, some strokes are deadly, um, and some heart attacks are deadly. And so there was an increase of people coming in and then having to take blood thinners for the rest of their lives to prevent them getting clots in the future.
And have you seen an increase in people who have then had, had come in for these clots and then they've, do you now see more people who are on long-term blood thinners? And has there been an increase in people who, were sort of permanently disabled, say by a stroke, or who actually died as a result of this?
I've definitely noticed a lot more people on the blood thinners, compared to when I first started in the NHS, and definitely pre-COVID. But like I say, whether that is because we know COVID caused clots, or whether it's the vaccines, or whether it's completely unrelated to that, and it's just the fact that society is so unhealthy now. As diet and being overweight will cause blood clots, drinking will cause blood clots, inactivity, sedentary lifestyles will cause blood clots, smoking will cause blood clots. So it's probably a good mix of things. But it's interesting that I have seen, and colleagues have seen an increase in these things since COVID. Um,
What other side effects have you seen? And I appreciate, and I really do the sort of objective stance of saying, look, it could be this, but correlation doesn't necessarily prove causation, and we need studies. Um, But throughout the time when we had, people taking these new vaccines, um, did you see an increase in other symptoms that at least correlated with the timing of the vaccines? Were people becoming sick from, are there other things people were coming in with complaints of during this time?
I didn't personally notice any other like potential side effects. We noticed after COVID and after all the lockdowns that people were coming in with a lot of flus and other infectious respiratory viruses because they hadn't been exposed to things for so long because of the lockdowns and the masks and everything. So it was a particularly bad flu season, I think, after COVID. Um, I think it's interesting to me as well that um, the people who were dying of COVID were people who had a lot of comorbidities, who were overweight. And apart from the vaccine program, there has been no other incentives from the NHS or the government to try and increase the health of the population. Um, this a bit of a tangent, sorry, but I feel quite passionate about the fact that I personally don't think that there is enough done to prevent illness in this country. And hey, you could say that that's pharmaceutical money, but who knows? I think it would be better to try and prevent illnesses than try and treat people with drugs and vaccines.
Yes, I agree. Although, as you rightly point out, there's no money in that for big pharma.
Yeah.
Um, and yeah, I mean, it's a tangent, but it's also very pertinent to what we're talking about. And I think it's very interesting that, as you say, during the whole pandemic, there seemed to be a very exclusive focus on lockdowns, masks, and vaccinations, and a bit of social distancing. But other than that, there didn't seem to be from the government and the NHS much talk of other measures that could have helped people to either avoid infection or be better sort of prepared to fight it off. And I think that's it's very interesting that when there's something on such a massive scale, a pandemic with a virus that we know people are going to be particularly susceptible to if they are unhealthy, if they are obese or morbidly obese. We know that there are these health risk factors. The government was spending so much time and energy and effort on trying to make people, stay at home and feel that they had to take, these vaccines. But I mean, why do you think it is? I mean, I know we kind of mentioned the financial incentive, but I mean, what's your view on the fact that we're not actually spending time, the government and the NHS, that is, trying to encourage people into the best way to safeguard themselves against these viruses, which is to be healthy and fit in the first place.
I think it predominantly comes down to the fact that changing human behavior is incredibly difficult. And any kind of campaign or program to improve public health is hard. Um, Even with the vaccine programs, for example, the flu vaccine, uptake is pretty low in the population, and it's even low actually within healthcare workers. Only sort of between 40 to 60% of us at the hospital took the flu vaccine. So to actually try and change behavior and encourage people to do something is very difficult, and it would take a lot of time and effort and money. So that's probably why. But I really do think that we're getting to a place now where we need to educate people more about what they can do to empower their own health and to exercise more, to eat better, to socialize. I mean, we know that loneliness is a killer, and the COVID lockdowns made people incredibly lonely. and people weren't exercising or eating properly. And it's sad to me that nobody post COVID has come out to try and change that.
Yeah, I think that's such a good point. And I remember a particularly absurd example of this. I used to live in Richmond at the time, and I remember people used to exercise in Richmond Park. I used to go for my morning run there. And a lot of people would cycle in the park. It's a very, very popular spot for cyclists. But I remember the day I walked into the park as one of my, daily allowances of freedom to get some exercise and have a walk and or possibly it was a run, but they had signs up saying that they had prohibited cycling
Yeah.
outdoors in Richmond Park, alleging that there was a risk of spreading the virus. And I mean, that to me, I'm not a qualified medical professional, but that seems nuts,
Yeah.
frankly.
Totally ridiculous, I think. It got completely out of hand, didn't it? The whole lockdown. Um, the amount of fear that people were feeling was something that I think us, especially as a young society, haven't ever had before. Um, and I think it spiraled out of control. Like you weren't allowed to exercise outside. I remember the local playground had chains on the gates. You weren't allowed to go to the park with your child. It was just mad.
Yeah, and things that just seem on the face of them that it's absurd that they would have actually had any positive impact in terms of preventing people from catching the virus. I mean, people knew that someone else might be contagious, so you probably would have kept your distance anyway.
Yeah,
Um,
exactly. Yeah, you'd like to think people would have common sense, but maybe
seems to
not.
be in short supply these days.
Yeah.
Okay, so another thing I wanted to ask you about, Becky, is we were just talking about how the focus on messaging towards the public was all around take the vaccine, wear the mask, stay at home, and social distance, and there was nothing around actually things you could do to improve your health that could make you far more, help your immune system to be stronger and better able to protect you in case you did catch the virus. But I wanted to ask you about treatments. Something that was, very controversial during the years of the pandemic was the various treatments that were reported to be effective at treating the COVID-19 virus. Um, and a lot of information about them seemed to be censored and suppressed, and the people who were trying to get the word out about them were often, sort of demonized and, called, you know, conspiracy theorists or what have you. And I'm thinking particularly of the drugs ivermectin and hydroxychloroquine. And then there was also the use of monoclonal antibodies. So in terms of actually treating the virus, which seemed to be, never part of the plan, and those drugs, I was just interested in your perspective. Are they things that you've heard about, that you know about, that you have used in your practice, uh, in working in pharmacy? Um, and yeah, what's your perspective on that side of it?
Yeah, I do remember a lot of talk that was mainly coming from America about hydroxychloroquine and ivermectin. They're two drugs that are licensed in the UK and that are used in the UK. We don't see too much ivermectin, but hydroxychloroquine is used for arthritis. So when people started to say that it was helping to treat COVID, I suppose, like for myself as a healthcare worker, I did find it a little bit strange and odd. I like thinking, how could this treat a viral infection when it's used for arthritis? So I think a lot of skepticism, like from me personally, was coming from that. Like, this isn't anything related to viral infections. So I'm not sure how that could help treat COVID, but I think going back and looking back, instead of just completely shutting these claims down, more studies probably could have been done on it, or studies probably were done on it, but maybe the results of those communicated a bit better. They're not things that we use now to treat COVID. We now use antivirals to treat COVID, and a couple of biologics, which are a bit like the monoclonal antibodies. But it kind of goes back to what I was saying about medical professionals shutting down any skepticism about vaccines, or questions, not even skepticism, just questions. Any questions that were being had were just immediately shut down, which is not the right way to go about things. I think there should have been more of a public health or a public science communication at the time to try and communicate the studies and the data and the results that were coming out, but that wasn't happening. Perhaps that's something that they need to consider in the future if anything like this ever happens again, God forbid. But I think what we've learned is that it's human nature to talk and ask questions, and that the government and the NHS, instead of shutting people down, should be communicating with those people, and providing more data and evidence.
It's interesting. Yeah, and I mean, the other thing I was also really curious to get your view on is kind of the darker side of potential side effects from the vaccinations. So I have a book by Edward Dowd, um, with a foreword by Robert F. Kennedy Jr. That's called "Cause Unknown: The Epidemic of Sudden Deaths in 2021 and 2022." And for anyone who doesn't know, Edward Dowd used to be very high up in BlackRock. So he's not just a random nobody, and he made his money being able to spot economic trends. And then he started paying attention to, and I don't know, Becky, if you remember seeing this and people kind of pointing it out, um, there seemed to be a lot of newspaper articles of young people who were dropping dead uh, inexplicably, and often during sporting activity. And this was happening. This was kind of correlating around the time that various, people are getting the new shot of the vaccine. They're taking the vaccine now, and then there seemed to be a correlation of people dying, and I believe myocarditis was what was often reported. Um, this book details, the kind of um, what it collects was the local newspaper reportings of these, because I think at a national level there was a lot of sort of control of messaging and a lot of censorship of this sort of thing, because they didn't want people to be, making that connection to the vaccine. But he's basically gone and got all the reports from local newspapers around, uh, around America and the UK and other countries, and it does present a pretty scary picture. Talking about the number of the excess death rate, and there's kind of the implication that although it's it may be difficult to prove in a particular case that the vaccine has killed people, the numbers here seem to be quite scary. I don't know at all like what your perspective on this is, how much of this you're aware of, if you're skeptical or not. But that's something else that I would be very interested to hear your view on.
Yeah, I do. I have seen that, like on YouTube and stuff. And I think from what I remember, it was mainly in young men that these excess sudden deaths were happening in. But I think there probably isn't enough evidence, well, there definitely isn't enough evidence at the moment to link that to anything specific. Sometimes you do see things that seem to happen quite a lot in a particular year, and sometimes it's for no apparent reason. Sometimes it is linked to things. But I think even if there were studies that were happening and it was being linked to the COVID vaccine, I would be doubtful that that would ever be released to the public because of the uproar that it would cause, and the amount of distrust it would cause for the pharmaceutical companies. I can't see that ever being released.
And there does seem to be a kind of a conflict of interests there with the pharmaceutical companies and, the fact that they make their money with the cure, and the cure requires that there are people who are sick who require the cure. Um, and yeah, I mean, what's your perspective on the relationship between the pharmaceutical industry and the NHS? Um, and how that kind of fits into things like, the pressure not to question the efficacy of the vaccine.
Yeah, the pharmaceutical companies have always been known to be corrupt and only about profit and money. I've never personally worked with anybody who I would say has been corrupted by the pharmaceutical company. Everyone I work with, which is interesting actually, everyone I work with in pharmacy is also skeptical of the pharmaceutical industry. But we rely on them to produce these drugs and develop these drugs. And they do go through a lot of processes to ensure the safety at the end. But like I said at the start, that process can take anything up to 20 years to get to. So you're talking about hundreds and hundreds of studies and thousands of people testing the drugs and the vaccines before it's deemed safe and before we know what side effects it could cause, before we know what dose is safe and what dose we should be giving in men, in women, in people who have got bad kidneys or bad livers. There's a whole range of things that need to be tested before it's deemed safe. And I think the relationship the NHS has with the pharmaceutical companies is very muddy. And they set the price. The pharmaceutical companies set the price, and if we want the drug, we have to pay for it, and it's terrible. And it's happened recently. There's been a new drug on the market for cystic fibrosis, which is effectively a cure for this awful genetic disease, which shortens people's lives. The people with cystic fibrosis normally only live till they're about 30, and a drug has been developed, but it's at the moment the NHS can't fund it, because it's something ridiculous like £500,000 per dose, which is disgusting that they can charge that. I think it's unethical, and I don't know how they can get away with it.
That does seem like an astronomical amount of money to charge for a single dose of a
Mm.
medication. And, you know, obviously that's only been decided on as a price in the knowledge that it would be paid for by, the NHS, because otherwise they wouldn't put a price. You wouldn't go out and sell a car that you expected a majority of people to be looking to buy, and charge £10 million for it, because there are very very few people who would be even able to pay for it, whether or not they were willing to pay for it. So how can it be that, I mean, What controls and safeguards are there in place in the NHS in terms of how they buy medications like that in to make sure that they're not being, essentially ripped off? Do they not have negotiating power to try and get a good price on these drugs? Or is there, when you say muddy waters, is there the possibility of corruption even, within the NHS of people who are, I'm trying to choose my words delicately here, but yeah, well, I mean, you can see where I'm kind of going with this. So, what's your
Mm.
view on that?
I think in all industries there's corruption, so undoubtedly there's probably corruption within this as well. But the drugs aren't bought willy-nilly. They have to go through NICE, which is the National Institute for Clinical Excellence. They decide what drugs are licensed in the UK, and they decide what drugs are bought for the NHS. So with the example going back to that cystic fibrosis drug, they on one of the drugs they rejected the price and they said no, we're not paying that, and then the pharmaceutical company came back with a lower price. So they do have some power of negotiating, but I'd say it's fairly limited, because the pharmaceutical companies can set the price that they want to sell it as. That starts to get a bit different though once the drug is off patent. So a patent is kind of like a trademark. So for example, Pfizer might have a drug. Let's use the COVID vaccine as an example because we know Pfizer developed one of them. That will be on patent for Pfizer. I think for maybe like 25 years or something ridiculous, like a really long time. So Pfizer will own the rights to that drug for, say, 25 years. And then at the end, then it will go out as a generic. And what I mean by generic is unbranded. So when you go to Sainsbury's or Morrison's or Tesco's and you buy paracetamol, that's unbranded paracetamol. A branded paracetamol would be Calpol. And the generic drugs are cheaper because more drug companies are producing them and manufacturing them, so the price goes down. So once that happens, the price of the drugs go down a lot, and Pfizer, for example, hasn't got monopoly over everybody else.
Right, I see. Yes, that makes a lot more sense. Okay. Was there anything else that you wanted to share with us while we're having this conversation, Becky?
No, I think we've covered quite a lot, haven't we?
We have, yeah, we've been going for probably an hour and 20 minutes,
Yeah.
maybe a little longer.
Um, no, I mean, if if you're happy to have me back, we can talk about more at a later date. I'm happy to finish if you are.
Absolutely, yeah. No, I'd love to have you back, and I know there are a few other things before we started the conversation that you mentioned that would probably be interesting to revisit in another podcast. So
Mm,
yes, I'd be very happy to do this again another time. So thank you very much for taking the time to have a chat with me today, and I really appreciate your insight and your perspective on going what it was like from the point of view of someone working in the NHS, going through the COVID pandemic and all of this. To everyone listening, thanks very much for staying with us. I hope this is a bit of interest. I hope it's been informative. If this is something you're enjoying and you would like to see more content like this, I am hoping to put out more podcasts. So please like and subscribe at whichever platform you happen to be listening to this on. Um, Thanks very much. Any comments or feedback will also be read and appreciated. And we'll see you next time. Thank you very much.
thank you. Thank you for having me, John. Um, please subscribe if you can, to the channel. And I would just like to finish by saying, I know I've been very miserable about the NHS today, but if you need them and if you're in trouble and you're dying, they will save your life and they are incredible. And the people who work there are amazing. Um, So please don't be discouraged to go to the NHS if you need them, because they'll always be there.
I think that's a brilliant note to end on, Becky, and a slightly more optimistic and uplifting one. So
Yeah.
that's perfect.
Thank you.
All right. Thanks a lot. Bye, everyone.
Bye.